So I'm Annie Joseph, a consultant microbiologist at Nottingham University Hospitals. So endocarditis is a condition that is quite rare, but it has a very high mortality. So the mortality is 100% in untreated endocarditis. And rather than it being an initial clinical suspicion, it's often missed initially and then the diagnosis becomes clearer later. So if you are called to assess somebody who is querying endocarditis, then they probably have a number of risk factors or clinical signs or symptoms that are suggesting that endocarditis might be the possibility. So for example, they may have a new murmur, and they may have a prosthetic heart valve in situ, or they may have a blood culture result that already suggests that they have a bloodstream infection. In that case, you're working a patient up ultimately to try and prove that endocarditis is the cause of their symptoms, and the Duke's criteria and the modified Duke's criteria are really the gold standard of defining whether somebody has infective endocarditis or not. So Duke's criteria is separated into major and minor criteria. So to have a confirmed diagnosis or a definite diagnosis of infective endocarditis, you need to either have the two major criteria together, or one major criteria plus three minor criteria. And if you don't have any of the major criteria, then you need to have 5 minor criteria. So the majors are obviously weighted quite importantly. Mm-hmm. And the two major criteria are around positive blood cultures. So having at least 2 sets of blood cultures taken at separate times which have a consistent organism in, and we can talk about what organisms they might be in a minute. And the second one is to have echocardiographic findings. So major criteria are positive blood cultures or echocardiographic findings. And the echo findings are around having a vegetation or a new valvular regurgitation, or if there's a prosthetic valve, then the prosthetic valve is leaking and that's new. So they're obviously quite high standards, and if you've already got those major criteria, you're already going down the path that this is probably endocarditis. Mm-hmm. So the minor criteria may be the ones which are more subtle. They might be picked up on clinical examination or from the history of the patient, and they may raise the suspicion of endocarditis before you get to the point of having organised an echo or got the blood cultures back. So they might be the ones where you're assessing to see whether endocarditis might be likely in that patient. So the minor criteria are things that we might remember from medical school. So for example, looking for embolic phenomenon, so things like splinter hemorrhages, Janeway lesions, Roth spots, and they're all the things that you may, potentially spot if you're lucky, but ultimately they're quite rare. One of the other minor criteria is around having a predisposing valvular lesion. So this is quite important in thinking in terms of who's at risk of endocarditis. So endocarditis used to generally be seen in people who'd had a history of childhood rheumatic fever, and that was generally the predisposing heart condition that would lead to most cases of endocarditis. But now rheumatic fever is so rare, it is usually associated with a degenerative valvular condition, so aortic stenosis, mitral regurgitation. So it's generally seen now in older people whose valves are getting calcified and crumbly and leaky as they get older, rather than having a condition originally in childhood that's predisposed them to that. But some people will have valvular abnormalities congenitally that might also be a risk. The other people who fall into that group of having a predisposing valvular condition are intravenous drug users. So the reason that their valves are predisposed to endocarditis is that when they're injecting drugs, all the particulate matter, so just dust and things that are made up in the drugs, brick dust and all of that sort of stuff, will damage the endocardial lining. So you'll actually have permanently damaged endocardium, which then is the perfect place for any bacteria that may be injected to sit on. So it's the particulate matter that predisposes them to endocarditis, but then obviously they're at higher risk every time they inject as well, of introducing bacteria that can settle on that damaged endocardium. Mm-hmm. Fever is a minor criteria. So the final minor criteria is microbiological criteria that doesn't meet the major criteria. So for example, if you had a single set of blood cultures that was positive and a second set wasn't obtained before antibiotics were started, so it gives you a higher suspicion, but it doesn't give you a major criteria of endocarditis. So we're talking predominantly about gram-positive organisms. So I'll kind of go through them in the order of prevalence of how often they cause endocarditis. So at the top of the list is Staphylococcus aureus, so gram-positive cocci in clusters, and causes quite an aggressive endocarditis and can cause quite progressive sort of valvular destruction, so can present very acutely. Often they don't have an indolent history with Staph aureus endocarditis because it produces lots of toxins, makes people quite septic and unwell, so it can actually have a very short history and endocarditis with Staph aureus. That's Staph aureus. Secondly is what we call the viridans streptococci. So viridans streptococci is a name for a group of streptococci, and the normal place where these streptococci live are in the mouth. So they're essentially mouth flora and usually very low pathogenicity, so they don't cause any problems. They're normal flora in the mouth, and for some reason they have entered the bloodstream and been able to seed to a heart valve. So potential ways that they can enter the bloodstream can be transient bacteremia from brushing teeth, and also from having poor dentition, dental abscesses, and that's where a predisposing risk factor may come in of having had previous dental surgery. So kind of a classical story might be having had dental surgery in the past couple of months and then a slow sort of indolent presentation which would fit with a subacute bacterial endocarditis. So it can be quite different to Staph aureus actually in the way that it presents, a bit slower, a bit more indolent. After that we've got enterococci. So enterococci are quite a similar group to streptococci, so they're not particularly pathogenic or naturally invasive organisms, and they'll cause a slow presentation as well. So they're quite similar in the way that they present, the viridans streptococci and the enterococci. Enterococci normally live in the gut. So the presence of enterococcal endocarditis might actually alert you to an underlying GI pathology, so potentially an occult malignancy that is yet to be diagnosed. And very closely related to enterococci is Streptococcus bovis. It's been renamed and it's got a couple of names now, a couple of biotypes which the microbiologists all like, but Streptococcus bovis is this kind of generic name, and that is very strongly associated with having a GI malignancy, and around 85% of people with Streptococcus bovis bacteremia will actually have endocarditis and a GI malignancy. So definitely one to think about if you get that in blood cultures. And then lastly, in kind of the gram-positive group, would be what we call the coagulase negative staphylococci. So that includes things like Staphylococcus epidermidis. So what we're really talking about is skin staphs. So normal flora from the skin that have managed to get into the wrong place. Very rare to cause native valve endocarditis, but it's the commonest cause of prosthetic valve endocarditis. So that's why it's important to remember coagulase negative staphs. They can be contaminants in blood cultures, but if you get them repeatedly growing or somebody has a prosthetic valve, then it may well be significant and require action. So where this becomes difficult is if you have a single set of blood cultures with a coagulase negative staph growing in it and somebody with a prosthetic valve or a pacing wire. So in that circumstance, it's very difficult to know, is that just a skin contaminant from the blood cultures being taken, or is it actually a genuine bacteremia associated with that prosthetic valve? So the importance of taking multiple sets of blood cultures is kind of really highlighted by that. And then to cover the gram-negative, so there are some gram-negative causes of endocarditis, much less common, perhaps things just to remember for the exam, what we call the HACEK group, so H-A-C-E-K, HACEK group of organisms. All get very long, complicated names, but we bunch them all together because they present very similarly and they're all gram-negatives. And they're also mouth flora, low pathogenic potential, and they present subacutely as well, so a long presentation. Okay, so in the pre-antibiotic era, as I said, mortality would be 100%. So antibiotics have revolutionised the treatment of endocarditis, but mortality is still quite high. So for something like Staph aureus, mortality can be between 20 and 40% still, lower for the less pathogenic organisms like the viridae streptococci. So it is really important to get the antibiotics right. And the antibiotics must be directed to the organism that we have isolated. So there really is no kind of cover for endocarditis. So occasionally as microbiologists we get asked the question, well, we think they're unwell, they have a murmur but we don't know if it's new or old, can we cover endocarditis? And ultimately the answer is no, it must be directed at the pathogen if we're going to have any chance of it being successful. The other kind of key feature of the antibiotic treatment for endocarditis is that it will be prolonged and it will all be intravenous. So it will be a minimum usually of about 4 weeks. On rare occasions that can be shorter to 2 weeks, but the standard therapy is 4 weeks of IV, and if they have a prosthetic valve or any complications such as emboli to distant sites, then it will be at least 6 weeks. And all of that needs to be intravenous. There's no oral switch, oral options. So that's why it's so important to get it right, because you are going to commit a patient to a considerable course of antibiotics and the need for a long-term line, etc. And in terms of the general principles, so for most of those organisms you can use a beta-lactam therapy as the sort of the backbone to the treatment. So for example for Staph aureus, if it's nice sensitive MSSA Staph aureus, then flucloxacillin would be the backbone for that. So for viridae streptococci, benzyl penicillin is the beta-lactam backbone to the therapy. And then we usually try to use combination therapy, and the reason for that is the difficulty in treating an intravascular infection where these organisms will be living in what we call a biofilm. So we'll basically be living very deep inside the vegetation on the heart valve. So you need to expose them to very high concentrations of antibiotics for very long periods of time for it to actually kill them. And we may use combinations such as gentamicin, and that's normally low dose gentamicin rather than the kind of once daily high dose gentamicin we generally use in the hospital. So there's normally a combination of a beta-lactam plus or minus gentamicin. One of the main issues that can come about and that makes endocarditis quite difficult to treat is allergies or reported allergies. So we know that about 10% of patients will report having an allergy to penicillins of some sort, but actually only 10% of those, so 1% of people, will have a genuine beta-lactam allergy. And for endocarditis it's crucial to try and find out what the allergy is and what they've previously tolerated, and it is one of the instances where microbiology may say we have to challenge that allergy because the therapy is so important here that we can't risk not using it. So in terms of, just to summarise that, for empirical treatment, always discuss with a microbiologist before starting any antibiotics. And if the patient's already on antibiotics and have been started already on something, but endocarditis is now perhaps becoming a consideration, discuss with microbiology as to what direction to go in and what tests we might be able to do to help with the diagnosis. So these are definitely a group where early involvement with the microbiology team as to the treatment would be sort of highly advised.